Epilepsy Q. What is epilepsy? A. Epilepsy is a brain disorder. It occurs when the electrical signals in the brain are disrupted. This change in the brain leads to a seizure. Seizures can cause brief changes in a person's body movements, awareness, emotions, senses, such as taste, smell, vision, or hearing. People with epilepsy have repeated seizures. Myth or fact? Myth number 1, epilepsy is rare. Fact, more than 2.5 million Americans have epilepsy. Myth number 2, epilepsy is contagious. Fact, you cannot catch epilepsy from another person. Therefore it is not contagious. Myth or fact? Myth number 3, epilepsy is a psychological condition. Fact, epilepsy is a medical condition. Seizures are the result of an excessive and disorderly discharge of electrical energy in the brain. Myth number 4, epilepsy is a form of mental illness. Fact, epilepsy is a functional, physical problem, not a mental one. It's an umbrella term that describes about 20 different types of seizure disorders. Myth or fact? Myth number 5, persons with epilepsy are epileptics. Fact, persons with epilepsy are individuals who experience chronic, recurrent seizures and prefer being described as persons with epilepsy. Myth number 6, you have to be born with epilepsy. Fact, epilepsy often first appears in children and young adults, although anyone can develop epilepsy at any time. Myth or fact? Myth number 7, epilepsy is a lifelong disorder. Fact, epilepsy is not necessarily a lifelong disorder. Many persons with epilepsy will not have seizures or require medication all of their lives. Myth number 8, you can't prevent epilepsy. Fact, while no specific cause can be pinpointed in a majority of epilepsy cases, some causes, such as severe head injuries experienced in falling from a bicycle or sustained in an automobile accident, have been identified. This is why helmet safety is so important for children as a preventive measure. Myth or fact? Myth number 9, epilepsy cannot be treated or cured. Fact, there is no known cure for epilepsy. However, modern treatment methods can achieve full control of seizures in a majority of cases. According to the IFA, 80% of those on medication have complete control of seizures. Within the past 15 years, several new drugs have been developed to help control seizures, and surgery is an option for some patients. Many people who have epilepsy lead productive, normal lives. Currently there is no cure, but some children tend to outgrow the condition. Myth or fact? Myth number 10, epilepsy is a disease. Fact, epilepsy is a neurological condition characterized by recurring seizures. Epilepsy is not a disease or a mental illness, and it does not signal emotional instability or lack of intelligence. According to the Epilepsy Foundation of America, EFA, 9% of the population will have a seizure at some point in their lives. Of this group, 3% will develop epilepsy. Myth or fact? Myth number 11, all seizures are the same. Fact, there are more than 20 forms of seizure disorders. The intensity and duration of the seizure depends on how many and what type of brain cells are affected. Seizures are not painful and range from convulsions to momentary lapses of attention. People with mild seizures may even be unaware they've had one. Seizures may occur minutes, days or years apart, depending on how well they are controlled by medication. Incidence over a lifetime, 5 to 7% of us have a seizure. 30 to 60 per 100,000 persons have epilepsy. Common in very young children. Most common neurological disorder of adolescence. 60% completely controllable, 25% can reduce severity, epileptic syndromes. An epileptic disorder characterized by a cluster of signs and symptoms which occur together. Factors taken into consideration include seizure type, etiology, genetics, anatomy, precipitating factors and the intra-rictal leak. Proposed by Ali in 1985, revised in 1989, currently under revision. Generalized seizures, electrical abnormality throughout cerebral cortex. Grand mal or generalized tonic-clonic seizures. Absence or petit mal. Atonic seizures. Generalized tonic-clonic seizures. Person stiffens, falls, and convulses, losing consciousness. EEG abnormal in more than 2/3 of cases. Cause in young children due to infection, metabolic disorder or trauma. In older individuals, usually due to trauma or tumor. Outcome dependent upon age, cause, and ability to control seizures. Approximately 40% retarded. Absence or petit mal seizures. Temporary lapse of consciousness that starts and ends abruptly. Brief periods of lack of awareness, may be unusual movements. Usual age of onset is 4 to 8 years. High genetic predisposition. Over 50% go into remission after adolescence. Generally normal IQ, only 5% retarded. Childhood absence epilepsy. Onset at 3 to 12 years. Peak at 6 to 7 years. Second peak at 11 to 12 years. Females more than males. Family history in 15 to 44%. Risk of generalized TC seizures is 30 to 40%. Increased risk if absence seizures begin after the age of 8 years. Childhood absence epilepsy treatment. Effective drugs: ethosuximide, valproic acid, clobazam, lamotrigine, topiramate. Ineffective drugs: carbamazepine, phenytoin, vigabatrin. Juvenile myoclonic epilepsy. A common cause of tonic-clonic seizures in teenagers and young adults. Indirect leak shows normal background with polyspike wave bursts. A photoconvulsive response is common. Juvenile myoclonic epilepsy. Diagnosis often delayed. Patients rarely report myoclonic jerks. Absence seizures occur in 25%. Myoclonic seizures precede tonic-clonic seizures by 2 to 3 years. Tonic-clonic seizures typically occur when patient reaches 10 to 17 years. JME, treatment avoid sleep deprivation and alcohol. VPA is treatment of choice. Clonazepam, lamotrigine or topiramate may be effective. Discuss teratogenesis for females and advise folic acid supplementation. Benign Rolandic epilepsy. Most common partial epilepsy. Onset 3 to 13 years. MF 1.5 to 1. 10 to 13% have a single seizure. 20% have frequent seizures. 65% nocturnal. 15% nocturnal or diurnal. 10 to 20% waking state only. Interictal discharge. Benign Rolandic epilepsy. Most common partial epilepsy. Onset 3 to 13 years. MF 1.5 to 1. 10 to 13% have a single seizure. 20% have frequent seizures. 65% nocturnal. 15% nocturnal or diurnal. 10 to 20% waking state only. Typical seizure: child 5 to 10 years with episodes. On waking, fully conscious, mouth to one side, salivating and focal twitching of one side of the face. Duration 1 to 2 minutes. Child may recall a sensation of numbness, pins and needles or electricity in the tongue, gums or cheeks. Secondary generalization may be seen. Atonic seizures, sudden loss of muscle tone, individual collapses. No tonic-clonic phases. Head injury is greater risk. Partial seizures, simple partial, focal, or Jacksonian seizures. Complex partial seizures. Generalized partial seizures. Simple partial seizures. Localized seizure disorder, which lasts a few minutes and is characterized by motor or sensory phenomena in a hand, arm or body part. Includes Jacksonian seizures, in which seizure moves sequentially from one area to another on the same side of the body. Most frequent between 5 to 15 years of age. 25% of post-traumatic seizures of this type. Outcome dependent upon where seizure origin is located, frontal lobe hard to control. Generally normal IQ. Complex partial seizures. Also called psychomotor or temporal lobe seizures. Individual loses awareness. Repetitive motor behaviors occur. Lasts 1 to a few minutes. Recovery includes confusion, irritability. Accounts for 2/3 of all epilepsies. Multifactorial causes, genetic predisposition, prenatal trauma, brain lesions. Generalized partial seizures. Sometimes partial seizures develop into full-body seizures. Usually this is when they are uncontrollable. Febrile seizures. Brief seizure in a child, which occurs in conjunction with a high fever. Occur in about 3% of young children. Peak occurrence between 9 to 20 months. Over 65% do not have subsequent seizure. If have multiple seizures, or associated with other anomalies, CP, then likely to have impact on intellect. Seems to run in families. Neonatal seizures may have a variety of causes, trauma, metabolic, or infection. If have multiple neonatal seizures, 40% mortality rate. 35% have mental retardation. If metabolic, especially due to drug withdrawal, outlook is better. Objectives: how to investigate possible seizures. History of greatest importance. How to approach epilepsy syndromes. How to predict seizure recurrence. How to choose an anti-epileptic drug, an approach to seizures. Acute symptomatic seizures. Meningitis. Encephalitis. Hypoxia, ischemia. Tumor. Vascular lesion. Hypoglycemia. Hyponatremia. Hypocalcemia. Trauma. Toxic process, causes of epilepsy: newborns, children, head trauma, infections, metabolic. Medications. Children. Fever. Infection. Toxins, lead poisoning. Epilepsy in adolescents. Most commonly occurring neurological disorder. Rapid changes associated with puberty may make seizures more common and severe, especially if grand mal type. Absence seizures may be improved. Due to psychosocial demands may be more problematic. Epilepsy in adulthood causes often trauma, or infections. Genetic predisposition. Emotional causes also documented. Developmental effects. Not an obvious disorder. Generally no intellectual disability. Personal psychological reaction of loss of control. Family's response to risk of seizure. Medication is crucial to control of seizures, especially difficult in adolescents, women with epilepsy. Pregnancy alters occurrence of seizures, usually making more frequent. Rate of major malformations is doubled for these women. Anti-epileptic drugs are associated with mild teratogenic effects, clefting, digit abnormalities. If seizure-free for 2 to 5 years, then drop drugs for 6 months to see if a single drug can control seizures. Single drug therapy associated with fewer malformations. Causes of epileptic seizures in children. Genetic. Congenital brain abnormality. Brain insult, for example trauma, meningitis. Progressive lesion, for example tumor, AVM. Metabolic, genetic causes of epilepsy. Familial neonatal convulsions. Benign familial convulsions of infancy. Benign partial seizures of infancy. Febrile seizures. Benign Rolandic seizures. Absence epilepsies. Juvenile myoclonic epilepsy.